COPD is our focus. This is a condition which affects over 1 million people in the UK, those with a diagnosis, and probably up to 3 million people in total. Globally, it's becoming one of the top 5 causes of death worldwide. So we're working very closely with GPs and practice nurses to make sure they have the skills to make a diagnosis of COPD earlier. In order to make this effective, we're using IT systems which the NHS commonly uses and taking the best of those to actually identify patients at greatest risk of this disease. So we think there's a big job to do. We think that we have a great team to do it. And I think each day is a challenge to take forward what we're doing and improve it. But the CLAHRC's really given us the machinery to make those changes. And we hope and expect to see good things from the programme.
So our theme is entitled Ageing and Dementia, Improving Routine Clinical Care, and we're very keen to improve just that, and so the routine clinical care obviously has a focus on nutrition of older people in hospital. The Southampton Mealtime Assistance Rollout Trial aims to build on previous research conducted here in Southampton, where we showed that we could train volunteers to effectively and safely help older people at mealtimes. We now aim to roll this out to 5 different clinical areas and to evaluate the recruitment and retention of volunteers, their activity in the different areas, the patient profiles and the volunteer profiles in different areas, in order to create a blueprint for other trusts to adapt and adopt the same programme but in their areas.
Our theme has occasionally been described as the post-Francis theme, and I think it really does establish what a vital issue it is. We know that people's experience in hospital is affected by how they interact with nurses, and they're very key to that experience. But the range of issues that we're trying to deal with run through from those softer issues through to basic issues of patient safety. We know that poor quality nursing care is associated with higher mortality rates. And I think we can't address those problems one at a time. So if we manage, as I'm sure we will, to identify a core set of priorities, to identify the interventions that nurses need to be using, but at the same time understanding the basic underpinning characteristics of the workforce and how that's organised in order to make sure that gets done, then the potential is that this work has a massive impact upon the experience of patients and their safety of their care.
Well, what we're really focusing on here is trying to reduce the use of antibiotics in consultations, and in particular when people go and see their doctor with a bad cough and they're worried that they may be really unwell or have pneumonia. And we know that by using a test at that point in the consultation, which takes 2 or 3 minutes, you can reduce the numbers of times that GPs will prescribe an antibiotic by around about 1/3. And so this project is focusing on introducing that technology, that new test, into practice, into real practices, and measuring the effects of that.
Well, in our theme, what we're trying to do is to help people use the support that's out there, make it more usable, make it more accessible, make it more meaningful. And as a theme, we're a cross-collaboration theme, so we're working quite closely with the other themes in terms of their research, because a lot of it, the research, is about how to help people manage their conditions and their lives better. So we're helping the other themes like primary care, like the respiratory theme, like the early stage dementia group, to use the tool, the Circle tool that we developed to map out social networks, so that they can use that in their research projects as well.
Many patients who come into hospital can often face an uncertain recovery. Our project is about a concept called treatment escalation planning. This is about responding to the fact that patients can rapidly deteriorate, and in those circumstances it's not always clear about the type of treatment or care management that maybe should or could be appropriate. So treatment escalation planning is a response to the fact that patients are facing uncertainty, and it's about talking within a clinical team with the patient and the family about the different choices and options that might be available. So as an example, about a decision about whether it's appropriate or necessary in terms of taking a patient to intensive care. Or alternatively, a patient's had a couple of courses of antibiotics, whether it would be appropriate to offer a third and different type of antibiotics. We often use the concept of setting a ceiling or a limit to treatment, and that's obviously about making a choice about whether that's appropriate for a patient or not.
So the hub has a dual role. So all the projects you'll have heard about, mealtime assistance, diagnosing patients with respiratory conditions earlier, the Hub is involved in all of those projects, and we provide things like complex data analyses, data and methods advice to the research team that are doing that. The second role we have is to work and collaborate directly with our NHS partners, so commissioners and trusts, to work with them on complex decision problems. So we want to help them by building mathematical models of the healthcare system and help them ask, what if we ran the system differently?
We sit patients and the public down with our researchers, and they can speak directly to them and share their views and make quite profound changes really to the direction the research progresses in, and really its success. It's crucial to its success, I would say.
I'd say that the influence that I have in research for the CLAHRC Wessex is trying to ensure that the right research is done and that research is done right.